Before we start talking about hypertension, let's talk just briefly about hypotension or low blood pressure. So orthostatic hypotension, as we mentioned earlier in one of the other videos, is just a temporary low blood pressure that results when you move quickly from a sitting or lying position into a standing position. This happens quite frequently in the elderly as you have an aged sympathetic nervous system, so the body doesn't respond as quickly, or the sympathetic nervous system doesn't respond quickly enough to that change in position, and you have a temporary reduced blood flow to the brain. This can lead to a condition called syncope or fainting. So that's just that sudden temporary loss of consciousness that's not due to a head trauma, but it's followed by a spontaneous recovery. It's most commonly due to a cerebral ischemia or loss of blood flow to the brain. So not only can orthostatic hypotension cause this little short-term syncope or fainting, but drug-induced syncope or fainting can be caused by drugs that are antihypertensive, that lower your blood pressure too much, diuretics that cause a decrease in blood volume by causing you to urinate more, vasodilators that are going to decrease the blood pressure within the arteries, of course, and then certain tranquilizers have the effect of depressing the nervous system reactions. There's another syncope called situational syncope that's caused by pressure stress associated with excess pushing during urination, defecation, or severe coughing. When you have increases, so your abdominal muscles are really tense, you increase the pressure as those muscles are pushing inward, and that can, along with the pressure that is being exerted by the muscles that are contracting, that can cause a decreased blood flow through the vessels in the abdomen. And of course we know the inferior vena cava is there, returning blood to the heart and just decreasing that blood flow, preventing sufficient blood flow to get back to the brain. Now again, these are very short-term, not really dangerous types of hypotension. Unless it is something that gets really, really low, the body will tends to fix itself pretty well. But chronic hypotension can be due to things that cause you to have less blood cells or less blood viscosity, and that is going to lead to a more long-term low blood pressure. Some things that can cause this, of course, are going to be poor nutrition. So with that lack of nutrients, especially vitamin B12, then you don't produce enough red blood cells, and without those red blood cells being in normal circulation in the normal amounts, of course you lose viscosity, and that in turn is going to decrease blood pressure. Hypothyroidism can decrease your metabolism and also decrease heart function, and therefore it decreases cardiac output. It's going to decrease your blood pressure. And Addison's disease is a disease where you have a decrease in aldosterone. Remember, aldosterone causes you to retain sodium and water. But if you don't have aldosterone, then you excrete too much sodium and water in your urine. So by decreasing the amount of water in the body, you're decreasing blood volume, and that in turn leads to a decrease in blood pressure. Hypertension is high blood pressure. It's known as the silent killer sometimes because it can cause a lot of damage to the blood vessels, the heart, the brain, and the kidneys before you ever really know that you have high blood pressure, because until it becomes really chronic and it's causing damage, there's not a lot of pain or other noticeable symptoms. It is, though, a major risk factor for the number 1 and number 3 causes of death in the United States. Do you know what those are? Number 1, heart disease, and number 3 is stroke. So high blood pressure is the main cause for both of these. In blood vessels, hypertension causes thickening of the tunica media. Remember, that's the muscle layer. It also accelerates the development of atherosclerosis and coronary artery disease and increases vascular resistance. In the heart, hypertension causes the afterload to increase, and that, of course, forces the ventricles to have to work harder to get the blood out. The normal response to increased workload due to vigorous exercise is hypertrophy, or overgrowing of the muscle, the myocardium, especially in the wall of the left ventricle, right? Because it's the one pushing that blood out to all of your body tissues. But this is a positive effect that can make the heart work more efficiently. In increased afterload, though, this leads to myocardial hypertrophy that's usually accompanied by muscle damage and building up of fibrous tissues, so a fibrosis of a lot of collagen fibers between the muscle fibers. So rather than the heart building up and becoming more effective, it's actually building up a lot of fibrosis and muscle damage, so it's becoming even less effective. So as a result of this, the left ventricle is going to enlarge, weaken, and dilate. Because the arteries in the brain are usually less protected by surrounding tissues than most of the other major arteries in the body, prolonged hypertension can eventually cause them to rupture, and that can result in a stroke. Hypertension also causes damage to the kidney arterioles. Remember, the kidneys filter the blood, and if you have constant high pressure pushing against the walls of those arterioles, then of course that's going to cause them to thicken, and that's going to narrow the lumen. That's going to, of course, damage those blood vessels, and they're going to be less able to get the blood out efficiently to the kidneys for filtration. Another thing that happens with that, of course, is because the blood supply to the kidneys is going to be reduced, the kidneys are going to detect that low oxygen and secrete renin. That's going to start that whole renin-angiotensin-aldosterone pathway that's going to lead to retention of more sodium and more vasoconstriction and increase the blood pressure even more. So now let's look at some of these facts and figures associated with hypertension. So about 50 million Americans have hypertension, what we just commonly call high blood pressure. It's the most common disorder affecting the heart and the blood vessels, major cause of kidney failure, heart disease, and stroke. In 2003, the guidelines for the detection, prevention, and treatment of high blood pressure were changed a little bit. And they were changed because there were so many clinical studies that linked what we first considered were fairly low blood pressures to high blood pressure, to the cardiovascular disease, the things that you see with high blood pressure. So the revision is as follows. So here on this particular table, you can see that the normal classification was previously considered optimal, is now going to be... Okay, sorry about that. I lost my train of thought and had to back up and think about what I was about to tell you. The normal classification, which is with a systolic less than 120 and diastolic less than 180, under old guidelines was considered optimal. That's what you should strive for. Now we know that blood pressure can be much lower than that and be what we consider optimal, because 120 over 80 is the borderline for pre-hypertension. So anything that is above that but still below 140 over 90 is considered pre-hypertension. So it tells you that you need to start watching your blood pressure and perhaps take steps to prevent blood pressure from increasing. So this just gives you classifications of the different classes, or the different ways of classifying hypertension based on what that blood pressure is. And of course, the higher the stage, the more aggressive the physician will treat your hypertensive state. Primary hypertension is about 90% of hypertensive population, and there's no underlying cause. We don't really know what's causing it, so there's not a disease, there's not any identifiable cause for hypertension to have developed. But some of the factors that can tend to contribute to that are diets that are high in sodium, cholesterol, and saturated fat. Those people that are obese tend to be more hypertensive. After you age, your blood vessels lose some of their elasticity, and high blood pressure tends to develop. There are certain races, African Americans are more prevalent to hypertension, so it does tend to be hereditary, or it runs in families. If you are in prolonged high stress situations, you're more likely to develop hypertension. And the nicotine in cigarette smoking enhances your sympathetic nervous system's vasoconstrictor effects. And that, of course, when you vasoconstrict, is going to increase the pressure in those blood vessels. But again, about 90% of the cases, we can say these things are contributing to it, but we really don't know what the cause is. Secondary hypertension, on the other hand, has identifiable causes that are making the patient hypertensive. So these could be that there's an obstruction of the renal flow or disorders that damage the renal tissue, and so the kidneys are releasing too much renin into the blood, and that's going to lead to high levels of angiotensin and vasoconstriction. Also, that's going to increase the vascular or the peripheral resistance, therefore even further increasing blood pressure. If you have damage to the kidneys and you're releasing excess renin, it's also going to cause excess aldosterone to be released. That hypersecretion of aldosterone may be because of the kidneys releasing excess renin, or it could even be a tumor, a proliferative tumor in the adrenal cortex. Either way, excess or hypersecretion of aldosterone is going to stimulate reabsorption of salt and then, of course, water by the kidneys, and that in turn, as you know, is going to increase blood volume and increase blood pressure. Hypersecretion of epinephrine and norepinephrine may occur because of a tumor in the adrenal medulla called a pheochromocytoma. So if that's the case, you're going to be releasing lots and lots of epi and norepi into the bloodstream. That's going to increase heart rate and contractility. Also, cause some vasoconstriction, and that's going to increase the vascular or peripheral resistance. And all of this, of course, is going to contribute directly to increased blood pressure. So regardless what the cause of your hypertension, there are usually some things that you can do to have some effect on decreasing blood pressure. Some of these are simply lifestyle changes. The best treatment for high blood pressure, other than using drugs, is simply weight loss. The loss of even just a few pounds can help reduce blood pressure in overweight, hypertensive people. If you drink in moderation, it may lower your risk of coronary heart disease, especially in males over the age of 45 and females over the age of 55. But drinking in moderation is defined as no more than 1 12-ounce beer per day for females, or no more than 2 12-ounce beers per day for males. So if you drink excessively, then you are going to increase your blood pressure. Drinking in moderation can be beneficial, but again, 1 beer a day for females, 2 for males, and only if you're of the age of 45 for males and 55 for females to get the benefit. Becoming more physically active, engaging in moderate exercises such as brisk walking or swimming several times a week for 30 to 45 minutes can lower your systolic blood pressure by about 10 millimeters of mercury, and that's quite significant if you are pre-hypertensive or stage 1 hypertensive. If you reduce your intake of salt, most of the people, or let me rephrase that, about half the people that suffer from hypertension are what we call salt sensitive. So a high salt diet in these people is going to promote hypertension. Of course, that leads to, when you increase your salt, you're going to increase water, increase blood volume. So sometimes just lowering your dietary salt intake can lower blood pressure. Also, maintaining the recommended daily allowance of potassium and calcium and magnesium. High levels of these three are associated with lower risk of hypertension. If you smoke, quit. If you don't smoke, don't start. Smoking has devastating effects on the heart, and this, of course, can augment or increase the damaging effects of high blood pressure by promoting even further vasoconstriction, which leads to even more hypertension. And then manage stress. There are several methods such as meditation, biofeedback, listening to music, spending time with people that make you happy. Anything that decreases your stress can decrease your daily release of epi and norepi by the adrenal medulla. And by reducing those, of course, you are decreasing their vasoconstrictive effects and also decreasing cardiac output, because remember, they increase heart rate. Now, in addition to just those environmental or lifestyle changes, there are several drugs that have different mechanisms of action that have been really effective in lowering blood pressure. Many people are treated pretty successfully with diuretics. Diuretics increase your urine output, so they decrease blood pressure by decreasing blood volume. ACE inhibitors, ACE stands for angiotensin converting enzyme. Now think about that again. Angiotensin converting enzyme. What does angiotensin do? Number one, angiotensin is going to be a vasoconstrictor. Number two, it turns on that whole aldosterone pathway. You know already what that does. So an ACE inhibitor blocks the formation of angiotensin 2. And if you block the formation of angiotensin 2, it's going to promote vasodilation, not constriction, and also decrease the secretion of aldosterone. Beta blockers reduce blood pressure by inhibiting the secretion of renin, also by decreasing heart rate and contractility. Vasodilators relax the smooth muscle in the arterial walls, causes vasodilation, lowers blood pressure by lowering peripheral resistance. An important category of vasodilators are calcium channel blockers. So these slow the inflow of calcium into those vascular smooth muscle cells. So they reduce the heart's workload by slowing the calcium coming into those pacemaker cells and into the regular myocardial muscle fibers. So it decreases heart rate by decreasing the force of contraction of those cells.